Welcome back to Introduction to Diagnostic Medicine. This is part 2 of Module 2. In this module, we will examine some of the metrics and mechanisms that are used to formulate diagnosis and determine disease using diagnostic tests. The learning objectives for this module include defining the term gold standard, identifying what makes a test useful as a screening tool, defining and calculating test sensitivity, specificity, and the positive and negative predictive value of diagnostic tests, describing how prevalence affects screening test results, and defining a few more definitions related to the use of diagnostic tests. As a review, diagnosis is an orderly decision-making process. We always start with the patient. You should be able to determine the difference between symptoms and signs, history, risk factors. So we get the patient information. A physical exam is done. Interpret those pieces of information, order diagnostic tests as appropriate, and of course, interpret. So we've talked about this previously. Interpretation is a very substantial and important part of the diagnostic process, and if not done correctly, the rest of it is really not very useful. A proper diagnosis aids in reducing morbidity and mortality. It's also important to understand the diagnostic testing process in terms of the phases of testing. So we apply quality assurance measures to each phase. So the pre-test or pre-analytical phase, these are things affecting the patient from collection of information, patient identification, test selection, collecting the specimen, sending it to the testing center if that's what has to happen. Lots of errors can happen here. Most of this work is managed outside of the purview of the diagnostic testing professional. So it happens before the patient goes to the imaging suite or before the diagnostic lab test is sent to the lab. The intra-test or analytical phase involves the things that the diagnostic testing professionals have the most control over, and there is a lot of quality assurance in this place, and the least errors happen here, but errors do happen. So error at any point of this testing phase can affect patient outcome. And then finally, the post-analytical or post-test phase involves the reporting of results, tracking patient results, follow-up tests, counseling, record keeping, and result interpretation. Again, this often happens away from the diagnostic testing professionals, and of course here's where the interpretation happens. If tests don't get reported properly to the right patient, critical results, important test results are not properly transmitted, of course interpretation can't happen because the clinician doesn't have the information necessary. We are going to spend some time talking about measures of test validity, and we need to understand these terms in relation to that. So the reference standard or gold standard is the approved method, the best method, the method we compare everything else to. So you might say, why don't we do the reference method testing no matter what? Well, usually this testing is more expensive. It's not readily available. It could take longer, and it doesn't make sense to use it as a general test for the population. These could be confirmatory tests, though. A false positive is just what it says, a positive test in a patient who doesn't have the disease, and a false negative is the opposite of that. It's important to know that false positives and negatives don't necessarily mean that an error happened or that the test is not good. Often it is a feature of the sensitivity or specificity of the test, and also individuals may have things unique to them that cause their test to be false negative or false positive. Sensitivity and specificity are measures of test validity, and these are specific to the test. Be sure that you keep that in mind. Sensitivity is a measure that tells us how well the test detects disease in anyone who truly has the disease. Or we could say it's the percent of diseased individuals who have a positive test. There are very few false negatives, and this is a measure that's best for screening tests. So a highly sensitive test will not miss any true cases of disease. And if we're screening, remember, screening is looking for disease in the asymptomatic population. It makes sense that you'd want a high level of sensitivity, close to 100. Specificity, on the other hand, tells us how well the test is at detecting non-diseased individuals as not having the disease. So no false positives. We also might say the percent of non-diseased individuals who have a negative test. So if you think about this, somebody had a screening test, it was highly sensitive, and they had a positive result. We would need to confirm that result frequently, and we would want to have a test that we know would be specific and not give us false positives. So a high specificity is good for confirmatory tests. To calculate sensitivity, we do the same thing, but now we're looking at the true positives and false negatives. Again, we have people who have the disease and tested positive. That's 190 of them. And we have people who have the disease and tested negative. That was 10. So of 200 people tested who were sick, 10 of them tested negative. This test sensitivity is 95%. So 5% of those tested across the population would have a false negative result, which we really don't want to see. So 95% might sound high, but it maybe is not the best sensitivity for a screening test. When we're calculating specificity, we need to know the number of true negatives and the number of false positives. So the four-square chart that you see includes people who have the disease, plus and minus, have the disease and don't have the disease, people who had a test that was positive and negative. So in this case, we have people who don't have the disease who tested positive, that's 50, and people who don't have the disease and tested negative, that's 200, and those are the true negatives. So we have 50 false positives and 200 true negatives. So our specificity is 80%. That means out of 200 people, or 250 tests, 50 of them were falsely positive, and at least for a while, those folks were diagnosed with having that disorder. Ideally, a test is sensitive and specific. 100% is both. In practice, we usually trade specificity for sensitivity. So if we have an increase in false positive results, we have a decrease in specificity. If we have an increase in false negative results, we have a decrease in sensitivity. Most of the time, we're able to confirm a positive result, especially if and that might be especially important if it's not matching the patient history. But so we often will choose sensitivity and not missing any cases of disease over specificity. Now we go to measures of test validity that help us to know if the information we're receiving is likely to be impacting the patient. So we're talking about predictive value. The positive predictive value is defined as the proportion of patients who test positive who actually have disease. And the negative predictive value is the proportion of patients who test negative who are actually free of disease. So how likely is a positive test to tell us that the person who has the positive test really has the disorder? These are not fixed characteristics of the test and do depend on the prevalence of disease and incidence of disease in the community. This is positive predictive value in just a different way. So if a person tests positive, what's the probability that he or she has the disease? And of course, vice versa. we talk about prevalence. So how much disease is there in the community? And this chart demonstrates to you how prevalence affects predictive value. The red line is a negative test, the blue line is positive, and you can see that as prevalence increases and gets to above 40%, the positive predictive value also increases and then levels off. As prevalence increases, the negative predictive value actually goes down. And when we have low prevalence and a negative test, we can be pretty sure that that person does not have a disease. It's truly negative. As the prevalence increases, we start to say, well, if there's this much disease in the community, maybe it doesn't make sense that you, individual, or more individuals have negative tests. So we have to consider something else. This is very, very common in epidemiology, and it's very important in understanding when interpreting the results of diagnostic testing. Here's an example of how we use predictive value to interpret the application of mammography screening. So mammography screening is an imaging procedure, low-dose radiation, intended for the early diagnosis of breast cancer. And there are fairly frequent revisions to recommendations of when women should begin having mammography screening, when they should stop, and how often they should do it. In any case, you can see that across all risk groups, even up to age 70, where the numbers of the prevalence of cancers is higher, the positive predictive value of mammography screening does not get to 20%. So that means that only 1 in 5 of an abnormal screening mammograms will be truly positive for cancer. And yeah, we continue to do mammography screening. It's widely accepted and widely adopted. And the reason is those people who are screened and who do have cancer theoretically identify that cancer before it's identifiable by a symptom such as a palpable mass, and can receive treatment before that disease becomes more severe, so metastatic cancer. But you can also see in younger age groups the positive predictive value of a screening mammogram is very low. And 97 women who have an abnormal screening mammogram in their 30s are not going to be diagnosed with cancer. That's good for people to know when they maybe have an abnormal test. Mammography is very sensitive. It'll pick up a lot of little incidental omas and abnormalities, but they are not specific to cancer. Here's an example describing how prevalence is important in determining predictive value. This map represents the incidence of Lyme disease, or the prevalence of Lyme disease across the United States. You can see Wisconsin has a high amount of Lyme disease. New Mexico, hardly any. If we have a negative test in New Mexico, we can be very certain that that test is negative, because there aren't going to be very many people at all who have Lyme disease in New Mexico. If we had a positive test in New Mexico, it's fairly likely that that positive test would not be a true positive. There's something impacting that particular individual or that test. The reason being is there are so few cases of Lyme disease in New Mexico. So where the prevalence is high, as in Wisconsin, and the test is positive, we can have a strong probability that that person has Lyme disease. Hopefully this is helping to clarify for you how prevalence impacts the predictive value. Let's move on to talk about screening tests. We're going to get a little more into depth about screening programs. Screening tests are designed to test large numbers of people, identify people who need additional testing, identify disease in an asymptomatic population. That's the definition we're using. It's easy to use. The test should be reliable, so we know that it performs well, and valid. So we want to know what the sensitivity and the specificity are, and hopefully they're high for both counts. There are expert organizations that make recommendations about the application of screening programs and when we should decide to do screening tests. So this could be a single test over many people. It could be a panel of tests that every person has when they go to their doctor. Now, screening can mean different things. But in any case, if we're screening, the condition should be important. So there's no point in screening for a self-limiting and mild disease, right? We're not going to screen for some kind of cold virus. There should be a treatment. Again, we have to consider, what are we screening for if we identify a disorder and there's no treatment? And there's more to it than this, but that's what the World Health Organization recommends. There should be facilities that can do the diagnosis and treatment. Again, does it make sense to take a screening program to a part of the world where we could get test results but not do anything else about it? It's good if there's a latent stage of the disease. So this means that the person is impacted, they're infected, or they have a early cancer or something that has not developed symptoms yet, because that's usually the best time to detect a disease and make screening worthwhile. Otherwise, if the person is symptomatic, we don't really need to screen anymore, right? The test should be, there should be a test for the condition. Okay, that makes sense. The test should be acceptable to the population. So if we need to be doing something invasive or personal or embarrassing or grossly expensive, that probably will not be accepted. We should understand how the disease works. We should agree on a policy about who to treat if the tests are positive. It should make sense economically. And we should be continually working on this. It shouldn't just be a one and done sort of project. So this is what the World Health Organization recommends when determining if a screening protocol should be put into place. The World Health Organization revised screening criteria in 2008 with the intent of clarifying and streamlining. You will see from these criteria that many of the conditions are similar. So a screening program should respond to a known need, and the definition and the goals of the screening program should be defined prior to implementing this program. It makes sense to define a target population, stratifying for population regions or risk groups. There should be evidence that the science supports the effectiveness of a program, and that this program should include education, testing, clinical services, and program management, with the idea of not just doing testing, but also educating the population and seeking improved outcomes. It makes sense that there should be quality assurance, reduction of risk related to screening. The population tested should be allowed informed consent or choice. They should be assured of confidentiality, and their autonomy should be respected. This somewhat precludes mandatory screening programs. The program should be equitable, and anyone who needs to be screened or wishes to be screened should have access. Again, there should be program evaluation planned from the beginning. This makes sense if we want to have effective screening programs. And as with all types of medical interventions, the risk should be less than the benefit. We use the term case finding. So case finding is really seeking individuals with disease. And the idea is that we use our resources to find a risk population and then offer screening programs. Often we see this in communicable disease control. And now you often hear the term big data. So we're using big data to identify risk populations and establish screening programs that make sense and are economically viable. We do have types of screening. So there's mass screening where everybody in a region or population would be screened. We might have high risk or selective screening. So these would be individuals who fit a certain risk category. Multiphasic screening involves screening across time, different times. And school-based screenings are the sorts of things we do in school. Children are screened for hearing and vision issues. Those are diagnostic tests. We might at one point have screened children for infectious diseases, and there are screenings for learning disorders and sometimes mental health. Those are all types of screens and diagnostic evaluations. So just kind of making it clear that screening isn't mass screen for every person in the community. There's variations on that. Here are some cancer screening protocols. We talked about mammography already. PAP screening is screening women for cervical cancer. Dermatology, skin cancer screenings. Colonoscopy and fecal occult blood, those are screening tests that are used to detect colon cancer. And in the case of colon cancer, every individual over 50 is recommended to have a colonoscopy, and then every 10 years after that. The PPD is a screen for infection with tuberculosis, either active or previous. There's screening for depression, prenatal screening, alpha-fetoprotein and other markers. Bite wing x-rays, those are dental x-rays. Those are screening types of tests. Screening for hearing loss in newborns. I give you this list to point out that we sometimes think of screening as one, some kind of laboratory test, and two, related to infectious diseases, when actually there's many screens for many different types of conditions. What are some limitations of screening? Well, we always have to consider cost benefit, adverse effects. What might be some adverse effects? False positives, subsequent testing, cost to healthcare to rule out false negatives, false positives, false negatives. We have to consider that. So if we have false negative results and somebody does have an infectious disease, when do we take care of that false negative? Or do we never let them, or do they never get retested? Again, adverse effects could involve things that happen to the patient. So colonoscopy is an invasive procedure. Something could happen to the patient. Failure to improve the outcome. So screening, diagnosis, maybe even treatment doesn't change anything. Maybe that's not a good cost benefit. A little bit more about interpreting the results of diagnostic tests. So we need to know the reference ranges. We already talked about the pros, cons, ins, and outs of reference ranges. We need to know the sensitivity, specificity, predictive values. That helps the diagnostic professionals know which test to select or implement. It helps the clinicians understand how to apply that information to the individual. We know there's always false positives and false negatives, so nothing is ever perfect. And we can confirm false positives and false negatives by testing for a different method or with a gold standard. I think it's very important for you to understand that tests that do not initially identify disease or lead us to a clear diagnosis don't always or often represent an error. It represents something about that test procedure itself or the individual themselves that are impacting the ability to get clear-cut information and achieve accurate diagnosis. A few more definitions for us. We talked about invasive and non-invasive. In vivo means in the living body. These are procedures that are done on the human. Many medical imaging procedures are done on the human, but some laboratory procedures are as well. And then in vitro is in an artificial environment. So the specimen is taken from the person and sent to a testing facility, and a large number of laboratory tests are performed in vitro. Invasive procedures require entry into the person through skin or a natural opening. You see an amniocentesis. The upper picture represents surgery, which is clearly invasive. Even phlebotomy, or the collection of blood, is invasive, but we call it minimally invasive. So it's really harm-free to almost everyone. We just need to follow proper precautions. Other types of invasive procedures include endoscopy, which is the insertion of a camera into a natural opening, so the colon or the esophagus, and catheterizations, which involve the insertion of catheters that might have viewing devices or medications or even treatment devices inserted into blood vessels. Non-invasive procedures then don't require entry into the body. A good number of imaging procedures are non-invasive, and you also see one here that is measuring blood oxygen through a pulse oximetry. And finally, we talk about public health. Where do diagnostics and public health intersect? And public health involves many things: social science, economics, and other disciplines besides diagnostics. But diagnostics is vital to the role of public health. Public health, it gets involved with screening protocols, with identification and control of infectious disease. So here's an example of public health working with polio, when polio was still an infection that people got. And without the diagnostics and the microbiology and other types of laboratories, it would be very challenging for public health to make a difference with their screening, prevention, and intervention programs. I just tell you that because we have a public health school, and some people might venture into public health as a graduate degree. This is the end of this module. Please be sure to check your module checklist for activities required. And again, I always recommend that you print out the notes. There is a transcript on these notes, and that you take notes as you listen to this lesson. Be sure in this case that you carefully read the lesson, the supporting material provided for the test validity measures. There are some additional test yourself kinds of tools available. It's a important subject and confusing when you first learn it, so give yourself the chance to practice.